think we'll go ahead and get started now. Hello, everyone. I'm Maureen Fitzgerald with CityMatCH. Welcome to the final 2016 post-training course webinar, Economic Evaluation in MCH with Dr. Scott Grosse. Based on feedback from previous webinars, it was determined that a more in-depth look at this topic was needed. We appreciate your flexibility, and we also are truly grateful to Dr. Grosse for stepping up to provide this. So let me briefly give you a bit of background about him, and his full bio sketch is in the update sent to you this morning. Dr. Grosse has degrees in economics and public health from the University of Michigan. He joined CDC in 1996, where he is the lead economist in the National Center on Birth Defects and Developmental Disabilities. Dr. Grosse has authored many journal articles and chapters, as well as scientific presentations and talks. He has analyzed data on costs associated with congenital or developmental disabling conditions and on the health outcomes and economic benefits of the prevention or early intervention for such conditions. The latter include cost effectiveness, cost benefit, and policy analyses on prevention strategies such as folic acid fortification, newborn screening, preconception care, and asthma management in children. In addition to his research on specific diseases and public health strategies, Dr. Grosse has published on health economic evaluation measures and methods. So we welcome Dr. Grosse's webinar. For our housekeeping, as usual, you probably heard the course is being recorded for archival purposes and for those unable to attend today. This webinar will begin with all phone lines muted, even our presenter. To unmute your phone, including speakers, press *7 on your phone. To remute your phones, press *6. If Dr. Grosse wants us at any point to unmute all the lines for an open conversation, we'll give you a heads up. So in case you're having a conversation around your desk about what you're seeing or keyboard activity, you can bring that to a quick close. I know we're all busy people. We're often multitasking. Please at no time place the webinar on hold. If you do have to step out, just keep your phone muted, or if you need to disconnect your phone line, go ahead and call back in as soon as you're able to. Leave your computer up and rolling. Lastly, if for some reason you're disconnected, just dial right back in and you can rejoin us. So this recorded webinar will become part of the 2016 archive to be posted to the CityMatCH website and will remain indefinitely. Dr. Grosse, at this point, I'm going to turn the webinar over to you and look forward to your presentation. Welcome.
Thank you. Next slide, please. Thanks. I'm going to begin with a brief overview of economic evaluation methods. There's cost analyses of various types, and then a full economic evaluation where you quantify the costs and health outcomes or benefits of a program or policy. And there's 3 different types of economic evaluation methods that I will be talking about. It's important to realize that one size does not fit all, that depending upon your study question and who your audience is, you may decide that you need to use one or more than one economic evaluation method. Next. So cost effectiveness analysis is what many people think of when they think of economic evaluation in health. The general approach is which approach costs less per unit of health gained. For example, if you're looking at asthma management, it's common to look at what is the cost per symptom-free day. Cost-benefit analysis focuses on monetary value of benefits and benefits to society, not just the healthcare system. Budgetary impact analysis, similar to cost-benefit analysis, looks at financial benefits, but usually the financial benefits and costs to a particular budget holder, such as a Medicaid program or a state government. Next. Cost effectiveness analysis is used to compare net cost per health outcome of different strategies with the same general purpose. For example, What is the cost effectiveness of screening versus no screening for the diagnosis of a disease, or two different screening algorithms? You compare outcomes and costs and calculate the incremental cost effectiveness ratio. This is the net cost divided by net health outcomes. Next. The different types of health outcomes that can be included in a cost effectiveness analysis include intermediate outcomes, such as cost per number of persons vaccinated, natural units of health, such as cases of disease prevented by vaccination or lives saved, and finally, health-adjusted life years, such as QALYs. Next. A cost-effectiveness analysis that uses QALYs as the metric to combine mortality, morbidity, and disability is also called a cost-utility analysis. Such analyses are very commonly found in medical journals. They're important to combine fatal and non-fatal outcomes. Disadvantage is that decision makers may not understand or appreciate QALYs, and hence this method is not commonly used in public health practice as opposed to peer-reviewed publications. Next. The key questions in framing a cost-effectiveness analysis is, what is your time or analytic horizon? How long into the future are costs assessed? 1 year or a lifetime? Whose perspective are you evaluating costs? That of a payer, all healthcare payers together, or society? And there's different definitions of a societal perspective. In 1996, a panel on cost effectiveness in health and medicine came up with recommendations where they defined a societal perspective as all direct costs, including patient family time costs. Just this month, the second panel on cost effectiveness in health and medicine came out with new guidelines, and they redefined societal perspective as including all health and non-health consequences. Next. Cost-benefit analysis takes all health outcomes as well as non-health outcomes and puts them in dollar terms. It involves lifetime analytic horizon with discounting of costs and benefits in future years. It is from the societal perspective. This is the dominant economic evaluation method used to inform regulations, both at the federal and state level, especially in the areas of environment and transportation. Next. There are two main approaches to putting a dollar value on health outcomes in cost-benefit analysis. Traditionally in public health, including at the CDC, the human capital approach of lifetime earnings, which is a little over $1 million at birth, was used to value the avoidance of death. This is the same as an indirect cost in a cost of illness analysis. Conversely, in the regulatory impact analysis field, economists use willingness to pay estimates, which are much larger because it includes the intangible costs of death. Typically, $6 to $9 million per death avoided or delayed is used in regulatory cost-benefit analyses. However, non-fatal outcomes, there's no consistent standardized method. Next. Budgetary impact analysis is better known as return on investment, or ROI. It is the calculation of the net financial cost to a stakeholder, which can be a provider or a payer or a state government. It compares the cost outlay and avoided financial cost to the same organizations. There is a short time horizon, typically 1 to 5 years. Outcome metrics include the ROI ratio, how many dollars saved for each dollar spent, net cost savings, or payback period, how long it takes for the intervention to break even from the perspective of the budget holder. It's important to realize that a budgetary impact analysis is not the same as a cost-effectiveness analysis, which is not the same as a cost-benefit analysis. Any of these study types can report outcomes in money terms alone. How you classify the study depends on the study perspective, payer versus all society, the analytic horizon, short-term or long-term, and which types of costs are included. Next. For ROI analyses, the length of period is typically a little bit longer for private health plans or employers, say 3 to 5 years. Medicare, often 10 years. Medicaid programs often just have 1 year. The ROI analysis of a publicly funded family planning program typically projects cost savings using a time frame of 1 to 5 years. The longer the time frame, the higher the ROI ratio. So if you're comparing different analyses of a family planning program, you're going to get different ratios. So some studies may report a higher ratio than another, even if the underlying cost savings is similar. For pediatric asthma management programs, which is a very popular topic for ROI, most show a positive ROI from the Medicaid perspective within 3 years. That is, the payback period is less than 3 years. Next. Any study can report outcomes in money terms. Cost effectiveness analyses often report negative net costs, in which case you do not need to report an incremental cost effectiveness ratio. Budgetary impact analyses and cost benefit analyses always report outcomes in terms of money. The use of terms may vary. For example, an article that was published labeled a cost-benefit analysis of the financial impact of postpartum IUD for uninsured immigrants in Oregon reported a negative ROI for the hospital and a positive ROI for state government. That is, from the provider perspective, there was a negative return on investment. For the state government, positive ROI. It saved the money that was avoided exceeded the magnitude of the cost. However, it was not a cost-benefit analysis as that term is defined here. It was a budgetary impact analysis with ROI calculations. It only looked at hospital costs. It did not include cost to the entire healthcare system or cost to other sectors. Next. Another example, there is a cost-benefit study of the Massachusetts Essential School Health Services or school nursing program, which compared the program cost with the program benefits in terms of reduction in direct costs. The net benefit was $98 million. This would be accurately classified as a cost-effectiveness analysis from the societal perspective, although only direct costs were included, and there was no monetary measure of health or other outcomes. Next. So which methods should you use? Cost-effectiveness analysis is commonly used in medicine and public health. The focus is usually on medical costs. It does not require one to put an explicit dollar value on health or life. And the subset of cost-utility analysis using QALYs is very appropriate for submitting manuscripts to medical journals. On the other hand, policymakers usually prefer analyses where the outcomes are all in dollar terms. It's easy for them to understand. Cost-benefit analysis allows for the comparison between health and non-health sectors, which is essential for interventions where the primary benefits accrue to other sectors, such as home visiting programs, childhood-led prevention programs. And even if it's not essential, it may be desirable to put health interventions on the same playing field in competition for budgetary resources with other sectors, other departments. Budgetary impact analysis, on the other hand, is highly attractive for interventions which have short-term cost impacts, where you can show a positive ROI within 1 to 3 year period of time. However, most public health programs require a longer time horizon to show net benefit, and because they affect multiple stakeholders, cost-benefit analysis may be more suitable. Next. The rest of the presentation, I will review 4 different maternal and child health applications of economic evaluations in which I have been involved at CDC. One is on asthma, the Easy Breathing program in Connecticut, folic acid fortification for the prevention of neural tube defects, which is at a national level, newborn blood spot screening in Washington State, and an adaptation of a Washington analysis, which was for severe combined immunodeficiency, which was adapted for the country and for use by other states. And finally, a recently published analysis of the potential cost savings from contraceptive access promotion during a Zika virus outbreak. Next. For pediatric asthma, the first step was to identify an effective intervention. And it's an important principle, I like to say, is effectiveness first, then cost effectiveness. Next, frame a collaboration to assess the ROI, which involves collecting program cost data and assess the financial outcomes, then prepare the analysis and disseminate the findings. Next. The Easy Breathing Asthma Program was piloted by the University of Connecticut and investigators in Hartford, Connecticut during 1998 to 2002. There was a citywide disease management program targeting urban children with asthma enrolled in Medicaid. An impact evaluation was published in 2005 showing a substantial increase in the use of recommended medications and corresponding reduction in healthcare utilization in hospital admissions and emergency department visits, as well as a smaller reduction in outpatient visits for exacerbations. Next. CDC approached the investigators and proposed conducting an economic evaluation, which I was invited to participate in. We did a potential ROI analysis. Because the program was funded by a grant and not by Medicaid, it was not calculating the actual return on investment to Medicaid, but on how much Medicaid in Connecticut could have saved if it had paid for the intervention. So what would the financial impact be in that scenario? So we calculated the intervention cost, the reduction in Medicaid expenditures, and calculate the potential ROI for Medicaid managed care plans in that state. Next. The cost analysis was a retrospective cost analysis of going back and looking at data collected from a parent survey, provider assessments, and budgetary data for the program for the different interventions. The cost components included the training and consultation, travel and forms. The total cost each year was divided by the number of children with physician-diagnosed asthma enrolled in the program that year. Next. Healthcare service use and costs. The service use was calculated for the period before the intervention and during and after the intervention. Utilization of services were assessed for Medicaid claims data, and unit costs were done from 2006 after the intervention, which was a retrospective cost analysis using the Connecticut Medicaid reimbursement rates. A statistical analysis was done by the investigators so that the children, based on the number of person months, they were contributed before and after. The Poisson regression models were fit to controlling for various confounders. Next. So this table shows the ROI calculation with the number of children enrolled each of the 3 years, the program costs each of the years, program cost per child with asthma enrolled, which was higher in the first year as the program project was ramping up, and then calculated the potential return on investment over the 3 years as a whole. So the difference between reduction in healthcare expenditures and program costs in absolute dollars, and the ratio, which was $3.50 to 1. Next. The ROI estimates were used in advocacy efforts by Dr. Michel Cloutier and colleagues. they persuaded the Medicaid managed care plans that they could actually save money by paying for the easy breathing intervention. However, the economic calculations, which should be emphasized, played a supporting role. It is showing a positive ROI is neither necessary nor sufficient to get funding for a program. Programs with strong constituencies may be funded even without evidence of effectiveness or ROI. And if you don't have good champions, even if you can show ROI, you may not get funding. So the ROI analysis is not magic, but it can be an important component of making the business case for why your program should be funded. Next. Folic acid fortification. The FDA required manufacturers of enriched cereal grain products to add folic acid beginning in 1997 by January 1st, 1998, followed a few months later by a similar mandate in Canada. The result was a 20 to 30% reduction in the number of infants born with spina bifida or anencephaly. We published a first economic analysis in the American Journal of Public Health in 2005. Next. We used cost-effectiveness analysis and cost-benefit analysis using the traditional public health human capital approach, evaluating deaths avoided at roughly $1 million. So we estimated the number of neural tube defects averted among live births using birth defect surveillance data. We estimated the lifetime cost of medical care and educational services using various data sources. So the avoided direct cost was estimated $146 million per year, including the cost of premature mortality and of permanent disability. That was roughly 3 times larger. The cost of fortification was estimated $3 million per year for a cost savings ratio of 40 to 1 and net benefit of 140 to 1. Next. Earlier this year, we published a new cost-effectiveness analysis in the American Journal of Preventive Medicine and a CDC-sponsored supplement on the use of economic methods in public health. Why? We had better epidemiologic estimates of the numbers of cases prevented. We have better economic estimates of lifetime cost for spina bifida, which accounted for virtually all of the avoided direct costs because infants with anencephaly die typically in the first week after birth. We included caregiving time costs, which were recommended by the first panel on cost effectiveness in health and medicine, but which we did not have data at the time of our 2005 analysis. And we adjusted for changes over time in healthcare costs, inflation in general, and for survival. There's been a dramatic improvement in survival among children in this country born with spina bifida. And we conducted sensitivity analyses to adjust for uncertainty in the model parameters, including fluctuation in the cost of the folic acid that is added to fortified food, which varied during this time period of the analysis between $4 million and $20 million per year. And also we did an adjustment for the fact that the FDA mandates in 1996 were actually 2 separate mandates. One that required adding folic acid to some foods, and another mandate which allowed for voluntary fortification of ready-to-eat breakfast cereals, many at a much higher level. This new analysis did not include a cost-benefit analysis because of controversies over valuation methods. What is the appropriate estimate of avoiding a death? And also, particularly, what is the economic value of avoiding affected pregnancies that do not result in a live birth? So we decided to make the analysis more straightforward by leaving out those areas of controversy. Next. So this shows the title, co-authors of that article. Next. So our estimates of the annual avoided direct costs were substantially larger, about $600 million per year, which is roughly 4 times greater than what we had previously estimated a decade before. but that included the caregiving time costs. If you see the second row, that $442 million is what you get if you would exclude the cost of family parental caregivers. There was a study done in Arkansas which showed that mothers of children with spina bifida are 1/3 less likely to be working for pay. And so we estimate about $150,000 to $200,000 lost in terms of lifetime productivity for parents of a child with spina bifida. Next. The use of the folic acid cost savings estimates. One contribution is building support for birth defects prevention efforts in general. And in addition to supporting ongoing efforts to expand folic acid fortification both in the United States and in other countries. Within the U.S., CDC worked with FDA to obtain approval of fortification of corn masa flour after having identified that the higher rate of NTDs among many Latina women in this country was due to their low consumption of fortified foods because of high consumption of products using corn masa flour which were not fortified. So now, going forward, those products will be fortified, which we expect to reduce that health disparity. And globally, there are many countries which do not add folic acid to food. And so the economic analyses in the U.S. can be used to inform estimates for other countries. Next. The third application is in the area of newborn screening. Newborn screening saves lives and saves money, but it depends on the condition. For some disorders, newborn screening saves lives, but not money, because you keep the children with a chronic condition alive who otherwise would have died, you're going to have high health care costs for those children. Whereas other disorders, the newborn screening saves money by preventing disability, but because it doesn't cause mortality, you're not saving lives. Screening for some disorders may save both lives and reduce costs. Hence, one size does not fit all. A financial ROI analysis, for example, would favor screening for costly conditions where you can prevent costs that are not lethal, whereas a cost-effectiveness cost-benefit analysis allows you to capture both the lethal and the non-lethal outcomes. Next. Washington State has been a pioneer in the use of economic evaluation to inform policies in general and including for newborn screening. For the past 15 years, the Washington Department of Health has created economic models to analyze the expected costs and benefits for newborn screening for every disorder that is added to the newborn screening panel in the state. I recently collaborated with Washington State in a narrative analysis of this experience, which was published in the Milbank Quarterly. Next. Severe combined immunodeficiency, or SCID, also known as bubble boy disease, is a rare disorder affecting only about 1 in 60,000 newborns. And some might think, well, why is this a public health priority if it affects so few children? Well, first, the condition is usually fatal within 2 years in the absence of treatment, but effective treatments are available, and the treatments are much more effective if begun soon after birth, which in the absence of an affected older sibling can only be done through newborn screening. Because of the evidence of effectiveness and after pilot studies in 2 states that showed that screening was feasible, SCID was added to the U.S. Recommended Uniform Screening Panel in 2010 using a molecular assay called TREC for T-cell receptor excision circle. State screening labs then needed to know not only is it worth doing, but what is the cost? What are the cost implications for the state from adding this new technology, new equipment, and new staff to screen for this condition? Next. So Washington State created a spreadsheet model, John Thompson and Mike Glass, the late Mike Glass, which they used to inform their own decision. Subsequently, the Association of Public Health Laboratories, APHL, collaboration with the Health Department, CDC, and Emory University collaborated on adapting this model to create an analysis that was published in a journal, and also as to create a software tool that other states could use, or other countries, to project the potential costs and benefits of screening for this condition. The cost-benefit analysis used an estimate of $9 million per death avoided, which was the standard estimate used by U.S. regulatory agencies, and then for sensitivity analysis used a lower estimate of $4.2 million because not all states will necessarily take the same approach as the federal government. So the software model allows the user to decide what dollar value they want to include. Next. The cost to the Washington Department of Health to add SCID was calculated by the Health Department. It's roughly $8 per infant. Then we also estimated short-term follow-up costs, the confirmatory costs. The total screening cost was very similar to the cost of just the screening test because very few infants require the confirmatory or follow-up support. Next. The net treatment costs, in general, treatment costs can go up or can go down. In the case of SCID, delayed diagnosis often leads to costly hospitalizations, and most importantly, the stem cell transplant, which is the primary treatment for most cases with SCID, costs much less if done in the first few months of life than later, because if done soon, you do not have to wipe out the infant's immune system. And also the success rate is much higher. Next. So the outcomes for this model, if you look at the column which says screening, these are the costs, assuming screening, and then no screening, costs without screening. If you look at the treatment costs for infants requiring definitive treatment, you see the cost is much higher without screening than with screening. Conversely, you also have the higher costs for the infants dying prior to definitive treatment. If you subtract the costs with screening from the costs without screening, you get the net cost of screening, which was treatment cost is $316,900. So the net direct cost with screening is subtracted from the cost without screening. So you get a net cost of $424,000. That is equivalently, they're saying roughly 40% of the cost is offset by the reduced cost with screening. Then the results of the cost effectiveness analysis, you calculate the net cost divided by the number of life years saved, and it works out to $35,000 per life year saved. That can then be compared with other interventions which avoid infant deaths. The cost-benefit analysis, using a $9 million figure per death avoided, works out to net benefit of $3.2 million, or a benefit cost ratio of 5.31 to 1. Using a more conservative VSL estimate of $4.2 million, there's still net benefit, and a benefit cost ratio is 2.7 to 1. Next. This is what's called a tornado diagram. You can tell why it's called a tornado. This is listing one-way sensitivity analysis so that you can see how the results vary depending upon the assumption, including the treatment cost per late identified infant, the assumptions about the survival among infants who are late identified. This was a base case estimate was 54%. We varied that between 38 and 72%. So you can see which parameters in the model are most influential. Next. The summary of the findings is the point estimate is $35,000 per life year saved, which is roughly equivalent to $40,000 per QALY. The estimate is below $100,000 per life year saved under any plausible combination of assumptions. the screening is cost beneficial even under the most conservative assumption about the value of avoiding an infant death. Next. And how have these results in models been used? The original model was not only used to inform Washington's decision to add SCID, but was also shared with some other states, including California and Arizona, who then used those models to help justify their decision or recommendation to add SCID to their state panel. The revised model was developed by APHL and published less than 6 months ago, may be used by other states that have not yet adopted SCID, although most states already have made that decision, and could be influential in other countries. Next. The final application is about a paper that was just published online 2 weeks ago on December 1st in a CDC journal called Emerging Infectious Diseases. This discusses the potential cost saving of increased contraceptive access during a Zika virus outbreak, specifically in Puerto Rico in 2016. The analysis was begun in March of 2016. It was completed in July, but only subsequently published. Next. The target population was assumed to be a cohort of 163,000 women who were sexually active with a male partner, fertile, not using permanent contraception, and the reason for excluding the sterilization is to avoid any controversy about that. Sterilization is a very commonly used contraceptive method in Puerto Rico for women not desiring pregnancy within the next 12 months. In other words, the goal of this was not to reduce the birth rate, but to help women in Puerto Rico who were concerned about the risk of having a child with birth defects because of the Zika virus outbreak. The hypothetical intervention was that same-day access would be provided to all types of contraceptive methods with no out-of-pocket costs to either the providers or to the consumers, including LARC, specifically intrauterine devices and injections. The healthcare providers would be trained to provide client-centered contraceptive counseling, and there would also be outreach to the community, including media, with contraceptive information. Next. The modeling approach was a decision tree model that compared the outcomes under status quo with contraceptive promotion intervention. The analysis was done using both a dedicated software program called Triage as well as Excel spreadsheet. The one-year intervention period was accompanied by an analytic horizon that was 1 year for most costs, except for a lifetime cost projected for infants with severe birth defects resulting from Zika virus. The healthcare sector perspective was used, although depending upon how you define the terms, you could call it a societal perspective because of the inclusion of family time costs. Uncertainty was modeled through various types of sensitivity analyses, including a probabilistic sensitivity analysis, where you do a simulation, multiple simulations, 10,000 repeats of the same model in which each parameter was varied within a predefined range. Next. This shows the decision tree. The one branch is followed all the way to the endpoints. The other branches are compressed. If you follow the group without intervention, you see how many, without the family planning intervention that we propose, how many women would use a highly effective method of contraception, specified the probability of becoming pregnant, and the different pregnancy outcomes. And among women who were screened in the middle of pregnancy, some would have a fetus recognized to have Zika-associated microcephaly, and others would not. And among those that did, we looked at modeled different pregnancy outcomes. Next. The epidemiologic estimates were taken from another CDC modeling study, which used data on other viral diseases in Puerto Rico, data from Brazil and other places of the risk of microcephaly associated with the Zika virus. The assumption was 58 cases of Zika-associated microcephaly and brain anomalies per 10,000 pregnant women. We also assumed that 35% of the recognized fetuses with these fetal anomalies would not be carried to term, based on data from the U.S. Zika Pregnancy Registry as of July 2016. Next. Contraceptive use distributions. We modeled the baseline distribution, which was challenging because of limited data. And then base case intervention scenario, which is we had different scenarios about what the impact of the intervention would be. A hypothetical intervention again. For the base case, we assumed that roughly 50% of women not using any contraception would visit a healthcare provider and receive counseling during the year, and slightly more of women using less effective contraceptive methods such as condoms. All women using moderately effective method users such as oral contraceptives were assumed to visit a healthcare provider during the year. Among women who visited a provider and received counseling, the assumption was that 50% would change to a more effective method, evenly divided between the moderately effective and highly effective methods. Next. That the contraceptive use distribution baseline, this was what we assumed. Next. This is the assumption with the intervention. In particular, highly effective methods such as IUD would go up from 2.6% to 23.5%. Next. Contraceptive-related costs were modeled, as well as costs of related services, including IUD insertion removal and provider office visits. Next. The cost of the intervention, the assumption was that it would cost $39 per woman in the target population that would cover the training of providers, education materials, outreach media, and program coordination. In addition, the assumption was that the extra cost of contraceptive counseling would be $10 per provider visit. Next. Results of this model. The total number of cases of Zika-associated microcephaly and anomalies would decrease by roughly 25%, and that would be true for all types of pregnancy outcomes. The cost of the intervention for family planning services would be an increase of $33 million. The total Zika virus-associated cost was estimated to fall by $65 million, most of which was the estimated lifetime cost of caring for children with microcephaly and severe brain anomalies. There were also minor costs or cost savings from avoiding the extra testing and monitoring and other pregnancy outcomes. So overall, the intervention was projected to be cost saving, just in terms of Zika virus-associated costs. Next. In addition, by allowing women to prevent pregnancies that were not desired, not just mistimed or unintended, but not wanted, the costs, just of cost during pregnancy care and during the neonatal period, the medical costs that would be avoided would be roughly $40 million, for a total net cost savings of $72 million. Next. We did one-way sensitivity analyses, which we considered multiple scenarios. And in most of the scenarios, net costs were negative. In only one scenario, if we assume that the intervention would have no reduction on non-use or use of less effective methods, would there be positive net cost, but the cost-effectiveness ratio would still be favorable, less than $25,000 per healthy life year or quality. Next. This is a scatter graph showing the probabilistic sensitivity analyses. There were 10,000 analyses done. Under most of those, net costs would be negative, that is below the dotted line. Next. Summary of results from this analysis. One is that providing access to effective contraception could reduce the number of unintended pregnancies in cases of Zika virus-associated birth defects by 25%. When considering only avoided Zika-related costs, the intervention is still cost-saving in almost all scenarios and cost-effective in all scenarios. Break-even cost of caring for a child with Zika-associated microcephaly was $1.9 million, which was half of the base case estimate of the lifetime present value of $3.8 million. Including costs of avoided unwanted pregnancies, the intervention would be cost-saving under all assumptions. Next. Major limitations. We had no recent data on contraceptive method use, pregnancy intentions, and rates of pregnancy loss in Puerto Rico, so we had to make a lot of assumptions. Second, this was a hypothetical intervention. We did not have data on actual effectiveness or uptake in Puerto Rico. Third, the actual risk of Zika-associated microcephaly was not known in this population. Fourth, the cost estimates for our model were derived from U.S. data based on health plans, private insurance. Costs for Puerto Rico are likely to be lower. And finally, the pregnancy intentions and contraceptive use in Puerto Rico or anywhere with a Zika virus outbreak would likely change even in the absence of a formal family planning or contraceptive access intervention. Next. That's all of the formal presentation, and I'm now ready to take questions.
Thank you, Dr. Grosse. I have a couple of questions that have popped up in the chat box, and I'll read you those questions and then remind participants if you would like to ask a question or have a conversation, press *7 to unmute your phone. And then once you're completely done, if you want to press *6, you can mute it again. The first question was from Ann Trin, and she said, what can local health departments do to contribute to CEA, CBA, BIA? Is it something that is more appropriate for state health departments to take on?
I think it is appropriate for some local health departments to do, but to do that requires establishing some collaboration with people who have some experience doing this kind of analysis. There are many health economists in universities throughout the country, and building that kind of a collaboration between your local health department and a state university is something that should be considered. There are some local health departments which have done this. Two that I'm familiar with are Maricopa County in Arizona and Los Angeles County in California.
Thanks. I don't know if Ann has an additional comment on that question. If not, I'll move on to the next one, which is, can you share any findings you are aware of for infant mortality reduction interventions?
I'm sorry, for what?
Infant mortality reduction interventions.
There are many different interventions which can reduce infant mortality. I've mentioned newborn screening as one. Rather than talking about interventions to reduce infant mortality, I think it would make sense to talk about maternal and child health interventions more broadly, some of which can be shown to reduce infant mortality. Take prenatal care. There are studies that have shown that women who receive high-quality prenatal care, their infants have a lower mortality rate. That may be because they're for various outcomes. It's not necessarily because of gestational age or birth weight, but better, more appropriate admission. Maybe it's because they're stopped smoking. There's many different potential mechanisms by which prenatal care can reduce infant mortality. The same would be true for preconception care can reduce infant mortality. Actually, if you mention like the smoking, there's smoking cessation during pregnancy is good. It saves money. It's cost effective over the long term. But it's most effective if it occurs prior to conception or in the early pregnancy, because smoking cessation early in pregnancy or before pregnancy actually has been shown to reduce incidence of low birth weight, which costs money and causes infant mortality. All right. Next.
Excellent. Those are the two questions that I had in the typewritten section. If anyone has a question, please press *7 and share your question now. You may have mesmerized everyone. I'll give it a little more time.
I hope I haven't intimidated folks.
It's been a pretty wonderful presentation.
Thank you.
Welcome. Any additional questions for Dr. Grosse?
Hi, this is Kristen. Scott, I just wanted to say thank you so much for presenting to us today. I think this gave us a lot of great examples of how this work could be done. I guess I'm thinking a little bit just kind of a broad question in terms of kind of the necessary data sources to embark on any of these analyses. So you talked about, understanding the program costs very well, and then obviously you need some kind of effectiveness study to estimate kind of the effect size of the intervention. But then when you're going to kind of estimate the, the cost savings as a, and I guess cost savings is the wrong word. I'm still not used to this terminology, but like what the cost of improving care or the savings, based on the intervention, what types of data sources are you typically using, especially for like state-based analyses like our participants might be using?
Well, let me give one example where I think a really great example is the Michigan Infant Health Program. Is there anyone from Michigan on the call?
We do have trainees from Michigan. I'm not sure if they were able to join today, but.
Okay. So this was a multi-year project where the Michigan Department, they've changed names, the health department collaborated with academic researchers to do an effectiveness evaluation using a fairly sophisticated propensity score statistical model to compare pregnancy outcomes for participants who received this enhanced prenatal care intervention, which included home visitation. It was not a clinic-based prenatal care model, but going beyond the clinic to target women who needed psychosocial support, care coordination, other services. And it showed significantly better pregnancy outcomes and lower costs. So the effectiveness data came from these very sophisticated analytic effectiveness data. Then the health department did an ROI analysis of showing, assuming this cost, like for a low birth weight infant, this is how much money could be saved. So the ROI analysis was pretty straightforward, because with an ROI analysis, if you've got dramatic reduction in healthcare costs or health outcomes, you can show a positive ROI within a 1-year period. So the ROI analysis that was done by the health department is online. And so that's an example, I think, that people could, that health departments could say, yes, this is a realistic model. It did not require any technical assistance from CDC. It's something that's doable.
It's interesting because I think we may have examined the effectiveness paper from that group in our training in June, but I didn't have the follow-up with the ROI. So I'll try to find that and circulate that to everybody. Or if, Scott, if you have it readily available, if you can send it to me, I'll circulate it.
Will do.
So when they were looking for the cost of a low birth weight infant, like, where do you go to find estimates of of what is averted? What are the costs that are averted?
That's a great question. For preterm births, we actually have the estimate from the Institute of Medicine, which published a book in 2007, Understanding Preterm Birth, and they calculated the average cost of a preterm birth is, I think, it was $50,000 as the present value. That was included both medical costs, education costs. So coming up with sort of a library of what are standard costs that you can use for avoided. It's doable for low birth weight. There's not a comparable estimate. Sometimes people will say, well, the cost for low birth weight infant is similar to a preterm infant. That's sort of a shortcut. And if your goal is to come up with an ROI analysis to inform decisions within the state, that's probably quite sufficient.
And then I suppose for other types of health outcomes, you could, if it's an ROI, you could partner with, like if it's to Medicaid, you could partner with your Medicaid agency to get some actual
Absolutely
data, right? Okay.
So your Medicaid program will be able to tell you, like, one thing that's important is what is the cost of pregnancy care? What's the cost if a complicated hospitalization? The average cost for a NICU hospitalization. Because that's really where your largest potential cost savings are, is anything that can reduce the number of infants who wind up in the NICU and the length of time in the NICU can save a lot of money.
Great, thanks. That's helpful. Just in terms of thinking, it sounds like, one of the hardest parts to doing a more simple kind of ROI, or something that may be asked of at the state health department level, is really identifying all of the data sources for these estimates. Would you agree?
Yes.
Are there other questions from the participants? Okay, in the absence of any other questions, I wanted to thank Scott again and then turn it over to Maureen. If you have any closing.
Yeah, one, I want to thank you, Kristen, for this entire year and the wonderful training that you've given the participants. Thank you, Dr. Grosse, for your presentation today. I think this was spot on for what was needed to close out the year, and we're really grateful. For the participants on the call, just a reminder that you'll be receiving an email later on today that will have a link to the archive and a link to the all-important survey. We need your data, as always. And that's it. Have a great holiday season, and you'll all be receiving a follow-up survey 1 year out about next July. So look forward to that communication.
It's been a pleasure working with all of you, and thanks for participating in the training.
Thank you, everyone. Have a good day.
Thank you.